Hi, hello. Well, I will talk about how the patient behave in one center experience with avatrombopag, focusing efficacy, safety profile, and some kind of treatment pattern that you use in clinical practice. Here are my disclosure for this presentation, and we'll follow the agenda of a brief introduction, the material methods, patient characteristic, the main efficacy outcomes, and intervention in this cohort, and finally I'll summarize with the conclusions. We all know that avatrombopag is the latest oral thrombopoietin receptor agonist that are in the market with approval, and some clinical trials and observational studies that it has a high efficacy and favorable safety profile that we find in the AVESPA study. We participate a lot of centers in Spain with more than 200. And it's to express my real data that from that center with a mean follow-up, with a long follow-up. So we included 23 patients diagnosed with ITP in a retrospective analysis from December 22 until today, with at least a minimum treatment exposure of more than 3 weeks. And I will record all the demographic characteristics of patient and disease, as well as adverse events. So primary efficacy at point, I define the overall response with more than 30,000 platelets and a complete response about over 100,000 platelets. Time to first response, time to achieve complete response, and I monitorize the longitudinally the platelets during the months 3, 6, and 12 months, as well as the last follow-up visit. And I record all the different avatrombopag doses administered to each patient with the safety assessments. This is the patient characteristic. They are all around 50 years, in the median 50 years old. We have more male than female, more primary ITP with more than chronic ITP with a medium platelet initiation around 50,000. And some of the patients were heavily treated with more than 3-4 lines. And one of them was in the first line. The detail of the cohort, most of them received corticosteroids or immunoglobulins during the follow-up. Half of them have received eltrombopag or romiflozin or both. And fostamatinib, and the more chronic ITP, they received a splenectomy or rituximab, because as you see from latency to AVA from diagnosis, they were a median of 26 years, but with an interquartile range until to 19 years, the most chronic one. The early lines was used around 3 months as a median and treated with more than third line, like around 15 years. Reason for switching was primarily loss of response or if you can respond to corticosteroid, and patient convenience in 3 of them, and 1 adverse event with previous treatment in other TPO. So the result of this cohort, that's most of the patients achieve a complete response in more than 80% of the cohort, 20 of 23. The 3 that didn't get response to were the most chronic ITP, heavily pretreated, and one of the other patient was another chronic ITP that they don't have response or an active response with avatrombopag in their first attempt. The efficacy outcome with timing, the median time to first response was 2 weeks, and the median time to complete response around 4 weeks. And the median time for last treatment on avatrombopag was around 9 months in all the cohort. So I would like to show some platelet counts and dose evolution with the treatment just to achieve the complete response or more than 50,000 platelets. We use a median dose of 140 milligrams per week, the scheduled dose of 20 milligrams per day. And when we follow up that patient during that time, with some of them with more than 1 year of follow-up, we found that some of the patients in the last visit they received the less treatment of around 60 milligrams, not per day, per week. So they need less than 20 milligrams per day. In most of them, with a platelet count more than 1,000. The different dosing pattern using clinics, more of them, more than 60% remain at the approved level scheme doses, but we have 8 patients that receive different schemes to achieve these platelet counts. Even one that they need less than 1 pill per 7 days. So I like to focus on something that I get remind my attention that the 3 patients that change for convenience from eltrombopag to avatrombopag they less need treatment than the one that received in one time avatrombopag during the follow-up of that patient. Just a curiosity, but 3 of them, they need like less than the typical 20 milligrams per day. And what about safety? In this cohort, there were mild effects, most of them headaches, asthenia as part of the disease, mild hepatotoxicity, and bleeding. I don't have any thromboembolic events in none of that patient. And I would like to show some of that we are talking about the early use of avatrombopag, because when I was reviewing this kind of patient, in 7 patients they received in the more primary ITP with previous, the median time between the last prior treatment and avatrombopag initiation in 1 of 10 with a median on 15 days. And with a median platelet count, all of them beyond the 30,000 platelets. So if we see that the result, the median exposure in that patient was 90 days, and the median time to respond was again around 2 weeks, with a platelet count with more than 200 in all of them. And what happened if you focus on the 4 patients that received very, very early avatrombopag, because some of them, they changed, well, to get IC discharge patient in that clinical, that's in the last year practice. So the days between AVA start and previous treatment was 15 days. The one who was from 5 to, with a minimum and maximum from 5 to 22 days. 2 patients received dexamethasone and the other prednisone. And the treatment exposure to avatrombopag was 7 weeks, with a median post-withdrawal follow-up of 8 weeks that will remain in response. Median time, again, to complete response, less than 2 weeks. And the platelet evolutions in avatrombopag withdrawal from complete response to end follow-up, they are still over 100 platelets. So this is overview of early use. 6 patients could withdraw treatment. 1 is still on avatrombopag. That one was in we start more later we will start later, like on things like 6 months or something like that. And in the last follow-up, that was for the maximum 6 months, they are in response. So we could conclude with this small series that, in aligning with the last publication result, that avatrombopag could achieve high response rate with a rapid onset, with efficacy in some multi-refractory patients, with durable response rates, and some with over time with the need of treatment with less than 20 milligrams per day, with a favorable safety profile and maybe a good response and tolerate with kind of a spare cortical use in maybe early setting as well.
Thank you, Denis. Thank you.
Thank you.
Nice talk. Can I ask, you mentioned hepatotoxicity in 5%, hepatotoxicity?
I have mild hepatotoxicity.
Would you mean that just raised ALT, AST?
Yeah, but they don't need to take over the treatment of avatrombopag.
Okay.
They elevate, I think they were more, maybe because of corticosteroid use or immunoglobulins that we sometimes see.
Because that's unusual with AVA. The liver function disturbance is unusual with avatrombopag, more so with L-trombopag.
No, not really. No more than when the trombopag. There are
L-trombopag is about 15%. Avatrombopag is supposed to have virtually no hepatotoxicity. Okay. Any questions for Denis?
Nice presentation and study, Denis. All these patients received 20 milligram initially, daily.
Yeah. For the initial treatment, they all received 20 milligrams per day.
I might have missed it, but did you see any thrombocytosis overshooting?
Yes, I didn't report it, but we have some thrombocytosis, but they resumed just stopping avatrombopag for 4 or 5 days or something, and they recovered to stable dose that we can resume the treatment.
Now
I think 6 patients has thrombocytosis.
How many? Six patients?
6 patients, sorry.
6 out of 22?
Out of 23.
23. Now I have changed my policy. I'm starting every other day, and I've conducted a small study, going to include 25 patients every other day, just to see. And it seems that we have included 21 patients so far, and only a couple of them required dose increase after 2 weeks. 1 to 2 weeks depends on. So maybe that will change to every other day.
Yeah, maybe some of the responders because of corticosteroid use, not all avatrombopag, but well.
Yep.
Thank you.
Yes.
Thank you so much. Thank you. Thank you.